Welcome everybody to this first meeting of the joint boards of NHS England and NHS Improvement. We're meeting here in public in London. The major audience for this will be on our live stream, and it's a great pleasure to be able to welcome members of both boards and to be accompanied today by my co-chair, Dido Harding of NHS Improvement. We will share the chairing of the session today. We have only 1 hour, but it's a very important hour. And I would like to preface the formal meeting by saying that over the past few months we have been working closer and closer together between our chairs, between our chief executives, and between senior members of the team, and now increasingly across the two boards. And we're doing that for a number of reasons which will become apparent during the course of the discussions this afternoon. I think, secondly, it's important to emphasize that this is the first step in what we see as a program of working more and more closely together. We cannot, by virtue of the statutory framework in which we work, merge the two organizations, but there is a commitment across the board that we should work as closely as possible as we can under that legislation in order to overcome any of the obstructions that otherwise exist to providing a seamless model of national leadership across our two organizations. So I'm going to kick off first of all by declaring apologies for absence, which we have from Dame Glynis Breakwell. I think everybody else is here. So let's move straight away into the formal business. I should say that we would record declarations of interest normally, but we both have our registers of interests, and so may we take those as read, because the work that we're looking at today is at such a high level that I can't conceive that there would be a direct conflict, but please do declare that should anything arise in the course of discussions. So our 3 items on the agenda today are items that we discussed yesterday in a very informal development session between the two boards in order to work them up into a state where we thought that was proper, that we could bring them into a public session and have a formal discussion around the table. So nobody should believe that these are papers that come to us cold and raw. These are the product of an enormous amount of work that's been going on between our two teams. With that, by way of introduction, may I ask you, Ian, to kick off in the discussion of the first paper, which is the next steps on NHS-E/I joint working.
Thank you very much, Malcolm, and it's a pleasure to be able to introduce this item. I think this is a very significant moment for us. The context for this discussion is clear. The NHS continues to deliver high-quality care for its patients, but we know that out there in the NHS, the response to an ageing population, a growing population, is about working to join up care, to create coherence and to create a focus for health in populations. That's a development from a focus on individual organisations. And I think the interesting thing that we're talking about here is that as we, as NHSI and as NHSE, think about how we support those frontline clinical developments, we need to recognise that, good though the work that both our authorities have done, we also need to change. We need to align our work in a way that hitherto we haven't needed to do. I think if I recall back to the March board, we signalled an ambitious intent to create a joined-up leadership for the NHS in England, with NHSE and NHSI aligning and working together. The proposals in front of us today outline the actions that we said we would be working on, and then we would outline to effectively move from what might be described as fragmentation of leadership across the English National Health Service to coherence, moving beyond conflicting messages where that sometimes happens between our organisations, to create a single view of how the NHS is performing, how it's developing, how it's spending its money, and to mobilise our collective resources for the next period of the NHS's history. For NHSI, it sits alongside a fairly radical set of changes which are very much supportive of our work with NHSE, but which actually take NHSI, look at NHSI and move us from a predominant, if not exclusive, focus on regulation to gearing ourselves to be an agent of improvement across the NHS. And so two sets of big changes, from a fragmented national leadership to a coherent national leadership, and from, for NHSI, a focus from ultimately being a regulator, a commentator, a judge, and then an intervener, into an improvement agency, an agency that is there on the pitch, in the front line, supporting organisations to improve. This needs to be done, of course, within the current legislative framework, as Malcolm has said, but within that, there's no question. Our intent is clear. We want to join up leadership for the NHS. What that means, in a nutshell, is as follows. The creation of 7 integrated regions for both NHS Improvement and NHS England, led by 7 regional directors with integrated teams, regional directors reporting directly to Simon and myself, and with a range of functions that is representative of a very significant devolution of responsibility from London to closer to the front line of the NHS. I think that would be a significant and welcome development for leading the NHS through its next phase. Not to be outdone by what we're doing at the proposing we do at the regional level, we need to look at ourselves nationally as well. And you will see here proposals for joining up some of the key areas, medical, nursing, finance, at the highest level to create that coherent leadership that I think the NHS will benefit from. I think in addition to that, we have worked hard over the last few weeks to take what might be described as a one NHS approach. And that means that where functions are hosted in NHS England or NHS Improvement, that increasingly that is hosted there but delivered on behalf of the whole of the NHS, on behalf of both NHS England and NHS Improvement. So to give one example of that, a focus on improvement for the NHS sits in NHS Improvement in future, but that's a whole NHS approach to improvement. Sits alongside a series of significant changes in the structure of NHS Improvement, creating a whole series of new posts to give us a more improvement-orientated focus, a new NHS Chief People Officer, a Chief Provider Strategy Officer, a Chief Improvement Officer, and a Chief Commercial Officer, those being many of the levers that alongside the regional directors and the joint directors of medicine, nursing and finance will be many of the agents of change that we need to support coherence in the NHS. Taken together, the corporate and the regional directors will form part of a new joint executive group, an NHS executive group, not a provider or a commissioner, but an NHS executive group chaired by Simon and myself, in order to provide a single leadership forum where we can take a full view of the NHS and its development needs. Other than that, I would only say one thing before finishing, that this is a significant programme of change. It is important. It's the subject of a significant amount of work, albeit there's more to come. It is about structures. It is about getting structures right. However, it's also about ways of working. And our aim here is to create a coherent approach to leadership across the NHS, to create the kind of working cultures between our organisations that will support the NHS best over the next few years, and to do that with the right structures so that we can get alongside the need for change at the local level. I think, Chairman, in the interest of time, that's probably enough from me. Perhaps hand over to my colleague Simon at this point.
Simon.
Well, no, Ian and I are obviously joined at the hip and the head on this, so I'm not going to repeat all of the great things that Ian has just said and that are laid out here in the board paper, which has been a product of a lot of joint work on behalf of people all around this table and our broader teams. I particularly want to thank Emily and Ben and Hannah for the leadership that they've shown, and maybe Emily wants to come in a moment. But also, frankly, to thank our staff in advance for what is bound to be an unsettling period over the next 4 or 5 months. We're obviously going to have a chance to have a conversation with all of the staff in NHS Improvement and NHS England tomorrow to deal with questions. Those of you who are watching on live stream this afternoon, you'll obviously have a chance to digest the materials here overnight, and then we'll be able to talk more about it tomorrow. But the reason we're doing this, as Ian said, is because, frankly, we need to be the change we want to see. And the change we want to see across the front line of care is a set of services and organisations which are much more joined up, where the fragmentation and the pushing and pulling is replaced by an approach to the health of populations that just about everybody sees is going to be required to future-proof the health and care system over the course of the next decade, which is the kind of planning horizon we are now embarking on. So practising what we preach, getting on with the job, ensuring we've got the right capabilities to do the big change programme that the NHS is going to need over the coming decade. That's what this is all about, trying to position ourselves for. So I think the detail is here. We will obviously be engaging with and consulting our staff where it has direct impacts, and Emily will be with colleagues leading that. So I don't know, Emily, if you want to pick up.
Emily, by all means.
Sure. So, I mean, I think Ian and Simon have already covered most of the content issues. I guess I was going to put a wrapper around it in terms of, first of all, it is, as we've discussed, the result of a huge amount of joint work already. And there are lots of people around this table who've put a huge amount of time into it, but also lots of people who aren't, who've worked very long hours to do it. And what that's built on is an extraordinary amount of joint working already. I think it's helpful to reflect on the fact that a lot of the things, for example, we talked about in our public board meeting this morning, are the result of existing joint working arrangements between NHS and NHSI. So this is a continuation, I think, of something that both organisations have been striving to do, and putting a wrapper around it in terms of aligning some of our structures and, perhaps more importantly, our processes and our governance and our culture and our ways of working, which perhaps haven't had so much attention paid as we've tried to make some of these programmes like mental health, for example, work together. So recognising that we couldn't have got here without all of that energy and without the foundation that had already been established, certainly before I joined NHS England 6 months ago. And one evidence, I think, of that existing foundation of joint working is when we held a session with about 20 executives 2 weeks ago, and we asked people to share, what would make this a success? How do we make sure, after lots of experiences, perhaps of people who've had long careers in the health service, of change programmes that perhaps haven't got exactly where they wanted to go, how do we make sure this one does? And the lessons learned that everybody shared in that meeting showed extraordinary commonality over a huge range of experiences in the NHS, talking about the need for a real clear purpose as to why are we doing this, and then using that purpose to drive all of the difficult decisions that need to be made to make this work. And that purpose, which Ian in particular has just spoken about, of setting ourselves up to make sure we can provide system leadership to the NHS in the most effective way possible, I think hopefully people will recognise is exemplified in the proposals today, but also needs to be continued forward in all of the further design work that we need to do, particularly in establishing a joint culture. Where, when we had our board development session yesterday, I think several of the non-executives shared views around that, which were extremely helpful, that we can't make joint working at the heart of the NHS work if we aren't clear what our working style is, how we make decisions together, and have an aspiration to do that in the same way. So looking forward to lots more joint work as we actually make this work for colleagues and start to deliver in that spirit of joint working.
Great, well, thank you very much for that. I think we would add just one rider on this, which is that the paper we've got today is very much and rightly focused upon executive joint working. We've got to work out the governance, which is the next layer that needs to go on top of this. And our commitment to that, this is a job for the NEDs actually, but the commitment to that is how do we make this as simple as possible? How do we get off the backs of people? How do we get clear, sharp accountability lines, and doing things once is reflected in the governance as well as in the executive action. So we'll take that away. We've made a start. I think the cross-appointments of David Roberts, who's a NED on the NHSE board, across to NHSI as an associate non-executive director, and the reciprocal appointment of Richard Douglas on the other side, has already started to open up lines of communication and accountability that previously were not there. So you've touched, Emily, particularly on culture, and it was a subject that we dwelt with on some time on yesterday. So I'm just going to invite comments from any colleagues around the boardroom table on how they feel that there is a need for cultural change. In other words, what have we got at the moment? And then secondly, what are the main things that we need to do as a board to drive a fresh approach to culture across the two organisations? Who would like to kick off on that? David.
Thank you. I think sort of, all organisational mergers, whether they be joint ventures, whether they be full mergers, in my experience, and I think the literature as well would support, succeed or fail on the creation of an appropriate and joined up and unified culture. And there are many cultures, I think, within these two entities. And therefore, I think the challenge to Simon and to Ian is, that you, Simon, quoted one of my leadership heroes, Mahatma Gandhi, in "We must become the change we want to see." And therefore, I think there is a lot of onus on these boards, and also but particularly to the two of you and your leadership teams, about working, as Emily said, what are the culture, what are the behavioural norms, and of course, saying it is one thing, doing it and living it is another, which will require real discipline. So I think it's, to me, that's as important as the structure. It's as important as some of the other factors. In fact, it's more important than those, the behaviours. I think one of the most interesting paragraphs in this paper is actually the last one, which talks about the behaviours and the culture. And I would encourage you, and indeed I think it will be incumbent on the board to hold you to account, to create the right to come back to us with your thoughts and ideas about what is the target culture. But to Emily's point as well, I was privileged to be in that room when we had that conversation. I was mighty struck by the fact that this is, I think, a very fundamental change between previously it was a top-down reorganisation to sort of try and drive a performance in to the people who are most important people, are the people who are looking after our people and our patients. This is actually fundamentally different. This is about a reorganisation in order to serve the people who are and the patients, because it's about us recognising that the world has changed and that we need to change the way we operate in order to facilitate change and better outcomes for people and for patients. That's a very fundamental change in the way we operate and in the culture we will need to have, which will test all of us. So it's a good challenge for both of you.
Thank you, David. Other comments? Moira.
Malcolm, it's not a comment about cultures because lots of people in this room will be attending to that, but I just wanted to acknowledge the very hard work that our executive colleagues have put into getting us to this place. I'm sure it has taken a lot of their time and attention, and to pay tribute to both chairs actually for clearly enabling that. Without your support they wouldn't have been able to do that work. But of course it is only the very first step, and I think the risk is in, as David talked to, in any of these kind of coming together, that the energy and focus turns inwards. And there is so much at stake in this NHS of ours in its 70th year that you can't allow that to happen. But it will be very hard to do both the internal stuff and the external stuff. So everything that they've already done will appear easy in comparison to the next stages.
The first test of this is going to be the next two items on the agenda. So let me invite any further comments on this paper before we go on to other items of business. Victor.
A reflection on the things that might bind us together that we're going to have to do work on, that we've made some progress, certainly in rhetoric, if not in... The first is diversity. I don't just mean diversity because whenever the black guy says this, if everybody thinks it's about race, it's about diversity of thought. To David's point, the future's created by the things we don't talk about, and that's often enhanced if there are different. So I'm wondering about how are we developing those themes that are cross-cutting but need to be developed in the governance and the leadership, because they will be reflected in what we do. And the other, given this morning's conversation in which we touched on themes of inequality, the extent to which these themes start here and are driven through the joint work of both boards into how we assess programmes, strategies, operations and impact on the people out there who are paying for all this. I'm just curious about how we address
Simon.
Comment on that. So Peter, that gives me an opportunity to also just set out, perhaps in a brief detail, the proposition in the paper around the creation of an NHS Assembly, which is going to be a national space where the stakeholders, both patient groups, voluntary community sector, clinical groups, as well as frontline leaders drawn from across different sectors of local government and the NHS come together, both to take stock on where the NHS has got to, but also to help co-design what the next 10 years will look like. And frankly, that will hold a mirror up to how we're doing and provide another forum for challenge to keep us on the true path. And we aim to have the NHS Assembly convened shortly before or shortly after the 70th anniversary on the 5th of July.
Really good. Sigurd.
Just some observations, really, more than anything else. I think, as we all discussed informally yesterday, it's quite clear that this is not only something we need to do and ought to do, but we probably ought to have done some time ago, but better late than never. The observations are really to do with, first of all, we mustn't underestimate the magnitude of the cultural change that's involved here. And that is, I think, particularly true when we look at the way we interact with our charges, if I can call them that, out in the regions. And that's going to be quite important to bear in mind, because it will, unfortunately, and in a way this will be very difficult, mean that a lot of people whose skills were appropriate to the roles we played in the past may or may not be appropriate in the future. And that will be, for Ian and Simon, a really difficult thing. The other observation that I wanted to share is that one of the few really important levers, apart from improved leadership that we've talked about, is obviously to really push the digital agenda, and we must avail ourselves of that to the fullest possible extent. There are not many ways that you can square the circle of rising demand and finite funds, even if we do get a little bit more now, but digital and pushing that in every sense, both to run our own affairs more efficiently, but also in improving patient care, is clearly one of them. And then finally, we will have a very interesting job of working out how we do improvement on the one hand, and on the other hand, intervene when local health economies are in trouble. And again, we need to pay, I think, quite careful attention to how we organise to do that.
Thank you, Sigurd. It should be of no surprise to anybody that at our public board meeting this morning, the answer to most of our impossible challenges was, we'll do it with NHS improvement. So it was true of maternity transformation, health inequalities, and mental health. And actually, I think there's a strong earnest of intention. We're very fortunate, of course, to have the chair of NHS Digital on the board, Noel, and I think you might want to come in at this point.
I did, Malcolm, yes, not specifically on the digital issue, but it relates. Culture is important, but so is style. And what I mean by style is apart from joining up organisationally and structurally, I think it's equally important when we meet that we join up our thinking. And typically we see things historically that have come through a very programmatic lens. And increasingly, I think we have the opportunity as we start relatively new to look at issues through a series of matrix lenses, through workforce, through technology, through inequalities, through what we do with patient and public voice. And actually, I would really like to see one change above all in the way that we debate and decide on issues, is that we get the multidisciplinary view of the problems that we have and the challenges that we have, as opposed to the classical programmatic or institutionally siloed view. Because joining up the thinking is in a way even more important, or at least emblematic of how we're going to join up the culture. And I think that style could also be a fresh start for many of for the way we look at many things.
Thanks, Noel. I'm going to bring in Richard, and then I think we need to move on the agenda. Richard?
Just a couple of quick points. And the first one, this is a fantastic opportunity, and one of the reasons it's a fantastic opportunity is this is something we've designed ourselves. We're doing because we think it's the right thing to do, and too many people around the room maybe have been scarred by other change programs where you're implementing someone else's template. But with that comes, without trying to quote Spider-Man, but comes a degree of responsibility around how we do it, because it does belong. It does belong to us. I just think we've got to really focus on the fact this is ours, we design it, we own it. But linked with that as well, linked to the question, it's not being imposed upon us. When we think about how we want to change ways of working and change in culture in the organisation, we're also got to be really careful of is not being dissing the past in some way, because the cultures and the ways of working were there for a reason. They worked in that time for the things that people wanted to do, and we're changing because the world around us has changed. The things we're trying to do have changed, and I just think when we deal particularly with our own people on this, we've got to be quite clear. It's not because the past was a bad place, it's because the world has changed, and I think we've got to hold that all the time when we go through this work.
Good. Well, thank you very much, Richard, and thank you all board members who have contributed. Before I invite Dido to assume the chair, I would just like to say that this is very big adventure that we're going on. It's really complicated. There's an enormous amount of work that's gone into it already, and it is today only the starting point of a significant change programme. Emily and Ben, I know, will do an enormous amount now to take forward on the next steps. But it would be wrong of me to close this item in the agenda without paying huge tribute to our two chief executives. This hasn't been easy. I mean, this has involved an enormous amount, not hand-to-hand conflict. That would be completely the wrong way of characterising it. Yes, hip welding and hand-holding.
Walking together.
But, you know, not to trivialise it. They are the ones who have taken the lead, and those are the ones who will bear the lead and the responsibility for the future. What you both need to know is actually the boards are completely joined up behind this. You will have the support of the boards, and we will not only hold you to account, but also help you to drive the changes with our staff and others to make this a success. So on that basis, may I invite you, Dido, to assume the chair.
Thanks, Malcolm. I'd just like to add one comment, which is I think that to echo Malcolm's, the way we do this is, if anything, more important than what we do. And I think the way that the two teams, our two CEOs and all of the executives working on this have been working on this is exemplary. And we need to keep doing that. So I think that in the back end of the paper, Project 70, our approach to really listening and engaging with our teams to make sure that we take the best of both worlds and make something even better. Both for the people working in NHS Improvement and NHS England and the citizens of the country and the staff of the NHS more broadly is really important. And I think you've made a very, very good start at that. And I think both of you said to each of us separately, to Malcolm and I separately, that more you talked, the more you discovered that you agreed with each other and the more opportunity there was to work together. And I think we'll find that going forward even more.
So with that, we need to do, as Simon said, we need to look out, not in, and we get that opportunity now to switch focus and look at where we stand together, and this really is the beginning of the new world of our joint view of where we stand in terms of the planning refresh for 18-19. Paul and Elizabeth, are you both going to give us a bit summary?
We are indeed. We thought we'd start with a nice easy topic for our joint work together, so sorting out the conundrum of 18-19 seems like it. To manage expectations, this is a progress update that Elizabeth and I are going to give on the financial and operational planning exercise. Although it is getting towards the end of May, this is not a completed exercise, but we think it's very important that both boards have a good understanding of where we're at the moment. In the context, Ida, of the discussion that we've just had, it's worth pointing out that this planning process itself has already been a good example of joint working in action, with everything from the creation of the planning guidance through to the setting of priorities for the system, and now the agreement of plans with local systems being very much undertaken together. And although this particular presentation of the state of affairs is being led from the bean counting corner, if I can call us that, it has very much been a multifunctional, multidisciplinary process involving operational colleagues and clinical colleagues. So it needs to be seen in that context, because we can't solve this from one disciplinary lens any more than we can from one organisational lens. I'm just going to give the briefest of introductions, and then with Elizabeth we're going to kind of give you the update on the various dimensions of it. The paper at paragraphs 9 and 10 reminds the board of the priorities we set for the deployment of the extra £2.1 billion that were made available to the NHS following the autumn budget, and the specific challenges that we set for each local system to work together to create credible and aligned plans. So the boards might want to have that in front of them. And essentially the rigorous assessment process, which Elizabeth and I and our operational colleagues in particular have been undertaking together following the plan submissions at the end of April, has been very much focused around the 6 key criteria for success, which again I'd like the boards to have in mind as we take us through this. The first of which, of course, is that we need organisations to create plans which show how they're going to deliver their part of the financial balance for the system, which we are committed to, incorporating the extra funding that we've given through the Provider Sustainability Fund, topped up, as we know, to 2.45 billion, and the new Commissioner Sustainability Fund. So question number 1 is, have we got to financial balance in both the provider sector and the Commissioner sector through individual organisations and systems meeting the expectations that we have set with them and for them? The second clear requirement is that we've got sufficient mitigation in place for the significant risks which every year in any decent planning process all organisations will identify for themselves. So that's the second test we've been setting, and I would just remind the boards that that's even more important this year, because we haven't got the cushion of a system reserve set aside at the beginning of the year to cover risks as they emerge during the course of the year. We've put all of that money into the available funds for organisations to put behind, in particular, the activity plans that they've generated. So it's really important that we've got a sound handle on the risk as we go through it. So that's the second test. The third one is we are determined to have plausible activity growth in the plans for 18-19, as a Freudian slip, learning from, frankly, some of the issues that we've had in 17-18 where activity planning was not up to scratch at the beginning of the year. We need to start this year with credible activity plans with a particular focus on emergency activity, which clearly was the big challenge for us in 17-18, but with an eye also to delivering on the commitments we've made around RTT. The fourth is, it's all very well to have activity plans and financial plans which deliver all that's needed. We need to make sure that organisations have got the operational capacity, in particular beds and workforce, to deliver the activity that we're planning for. Fifthly, we need to make sure that we achieve the holy grail in the NHS, which even in Richard's time, looking after the central finances, we never quite cracked, which was to have commissioners and providers planning for the same amount of cost and income in an entirely consistent way. We are determined to have that sorted out this year. And finally, we set some very clear expectations of commissioners with regard to investment in key priority areas, and I would single out particularly mental health and primary care. So those 6 lenses are the way in which we've been looking at the planning process, and which now we're going to give you a very brief kind of non-numerical update. Clearly, when we've finished the process, we will furnish the set of numbers which deliver on those 6 things. The good news is that the April submissions that we had from commissioners and providers were a substantial improvement on earlier draft plans that the boards will independently have seen. And all but about 30 organisations, concentrated in 15 of our most challenged health economies, have now confirmed in their plans that they'll deliver the required financial performance. The bad news is that some of the exceptions are pretty big. So over the next few weeks, the real focus for financial balancing is to be working with those health economies to work out what set of actions will get the gaps in their plans to be eliminated in ways that they can deliver. It's already evident from the work that Elizabeth and I have done with the regional teams that in quite a number of those places some really difficult choices are going to have to be made in order to close the gaps that they are showing in their latest set of plans. And it will be a very important test, I think, of our shared endeavour, both nationally and regionally, as to how, as we go through those, in particular the top 15 health economies, how we can manage to galvanise action to make the right difficult choices in order to get all of that sorted out. So that's the financial balancing. We'll come back to all of this in discussion, I dare say. Yeah. The level of risk reported alongside the plans is significantly lower than in previous years. That's an important factor, I think, in all of this, but it's still higher than it needs to be to give us the assurance that I talked about earlier on. It mainly reflects, as is often the case, cost improvement plans on both commissioners and providers, which have not yet been sufficiently well identified and underpinned with credible actions. That was the case last year, and I'm afraid that on the whole, risks that we identified at the beginning of the year with unidentified SIP plans translated by the end of the year into overspends on the part of the organisations concerned. So it's vitally important that in the next 3 or 4 weeks we do identify and then underpin the SIP plans and the QUIP plans in our wonderful terminology, the efficiency plans of commissioners and providers, so that we don't have all of that falling out at the back end of the year as under delivery. So that's the SIP plan. Did you want to comment at all on SIP plans and how we're working on that, Elizabeth?
Yeah, so in addition to the points that you raised in terms of the tests, Paul, I know it was inherent in what you said, but another key test, obviously, that is the very front of our minds at the moment is the potential impact of quality on the plans. I think that's really important. So this is in respect of the extent in which constitutional standards are met, but also in respect of the quality impact assessment of the SIPs and QUIPs. Exactly. That are coming through. So jointly across the teams with clinical colleagues, we are working hard at it to sense check the plans, but also to, with clinical colleagues out with the providers, to understand the ramifications of the savings plans that are coming through. So once again, we're seeing quite high numbers. We're trying to assess the risk of those and what those mean. When we're looking at the SIPs plan, we're also looking at the quality and the assumptions made about capacity planning, and that again, so it's great that the plans are more aligned. We need to make sure that they are realistic, and as we currently stand at a very top-down modelling approach, it looks as though we need the extra capacity, and with that, working with clinical colleagues again, we are concerned about whether or not the workforce actually exists, or that might be appropriate, and we need to understand how perhaps we harness some of the length of stay initiatives and other things that we know that are out there, and with our productivity colleagues, we know that they're out there to capitalise on. So lots of work going on, a huge amount of joint work. I'd just like to echo that this is not the start, as Paul said, of the joint working. This has been going on since the autumn probably, It's been fantastic, in particularly how the planning teams have worked together, regularly meeting, but also the regions. So at a regional level, we've never been at this stage of a planning round where we've had such tight and close understanding of the planning gaps and the contract gaps. And that's really positive, that even if there is still a gap at this stage of the year, we actually understand the level of risk collectively. So that's very, very positive from previous years.
So if I may just round off the 6 tests, we've talked about balancing, we've talked about SIPs and QUIPs, both in quality terms and in terms of identification and confidence in delivery. The third one was activity. The good news on activity is that the systems have come back with plans which respond directly to the challenge that we set on non-elective volumes. So we asked systems to plan for 2.3% of growth in activity in aggregate across the country. The good news is both commissioner plans and provider plans at national level and in general across the country have come back with almost exactly that number. So the system is planning for a much more sensible level of non-elective activity than was the case in 17-18. The more challenging part of it is whether the level of elective activity that's been planned for, particularly by commissioners, there is a difference between commissioner and provider plans at the moment on elective volume, whether either of those sets of volumes actually is sufficient to deliver on the commitment that we've made that waiting lists will be at worst stabilised. And that's the piece of testing that we will need to do in the context of real expectations over the next few weeks. I think you've referred to the 4th test, which is capacity planning.
Yeah.
Have you covered that sufficiently?
Yeah.
So that's a very big part of what we're doing over the next few weeks. On cross-sector alignment, which, as I say, is the holy grail, which we are attempting to do. The great news is we've got much greater transparency on this year than we've ever had before, helped greatly by the fact that STPs have taken on this particular challenge to bring all this together. With transparency, of course, comes knowledge that which we therefore need to respond to. The good news is, whilst there is still a gap, it is a much smaller gap than we think we've ever had before, which again speaks, I think, to the consistency of the planning around activity. So we have still got to wrestle down some small gaps. Something well over 90% of the country has now got agreed contracts, which is a good piece of development. And there is probably a handful of places that have got serious issues still with their contracts where we're going to need to support them to come to conclusions on that. So I think good progress being made, but we still have a bit of work to do. And the final thing is a small piece of good news, which is unusual for finance people to bring in any board meeting, but let me break the habit of a lifetime. So mental health investment standard and primary care investment, the two big totemic investments that we were very keen. I'm not doing the good news very well.
When finance directors try to give good news.
So the very important investments which we required people to make are secured within the plans. There is not a single CCG in the country that has not fulfilled, that's a double negative if ever there was one, the mental health investment standard, and every single CCG is investing the right amount of money in the additional investments behind GP access and scaled up working. So we've got at least those investments sorted out, as well as say, a large part of the activity conundrum, I think, solved. So in that attempt to bring this discussion to at least our presentation of it to a positive end, I guess we open to questions, observations, and contributions, financial or otherwise, from around the table to the Balancing Act.
Thank you both. Sarah, would you like to kick us off?
First of all, glad to hear there's some good news, and that gaps are closing, which is what we like to hear. I hope that to the extent that that's the result of closer working out in the regions, out in the localities, that the finance staff out in those places are finding that a good experience, because the closer they work together, obviously, we want to know that everything that we're doing is going to make things better out on the front line, so that's good. The question I had was whether the plans for A&E attendance growth, non-elective growth, whether you were still comfortable with those numbers now we've had the winter, because of course those assumptions will have been set at the beginning of the winter. We've been through a very challenging winter. Are they still the right assumptions?
Elizabeth might have a view. Indeed, other colleagues, Matthew and others, might have a view on that. It is undoubtedly the case that since we set the benchmark for the planning, the growth for last year was higher than the 2.3 that we set. I think 3.4% is, roughly speaking, where we end up for the whole of last year. And I think the judgment we have to make is whether there were sufficient particular factors in 17-18 that lead us to think that we will still be okay with 2.3%. I can point to the flu incident, obviously, as being a specific. We can think of some of the aspects of winter and the length of winter that we had as being specific. And I can think of one or two aspects of the, if you like, recording of activity, which I think will lead us to have a slightly overstated view as to what the trend is. There is undoubtedly a risk that 2.3% will not be quite enough for the winter. I think we're an awful lot better off, though, having secured 2.3% of activity in the plans than having something which in previous years was rather more optimistic than that.
Yeah. Could I just add the other thing that is very positive this year is the profiling of activity. So it does look more realistic. Within this, so everything, so not to caveat the good news, within this we've got variation. So we've got some very good plans and we're in a much better place, but we've still got further work to do across this. So a very good set of plans. But on winter, I think we've obviously started the winter planning as well earlier in the process with the help of Pauline.
Thank you. Bruce, you wanted to come in and then Matthew.
Just wanted to go back to this being a more than just a finance function, and so thank you for recognising that, because we as clinical colleagues have had to have a discussion as well along with you about how we support our clinical colleagues out in the provider sector and I'm sure in the commissioning sector with their quality impact assessments. And at the STAR chambers that we've sort of halfway through at the moment, been thinking about how we support our providers, whether that's around workforce or whether that's around quality impact. So together I think this greater alignment will allow us to do that even more focused, so more benefit for the frontline directors. It's really important stuff.
Matthew?
So I just wanted to come back to the numbers point, because we did, seeing that the growth was higher than the end of the year, we did go back round the regional directors and say to them that when they're assessing the plans, they need to bear that in mind. And looking at the numbers that have come through, if you look at the overnight stay emergency admissions, we asked people to plan against 0.9% growth, and they've actually come back with 1.3. So they've come in higher than the numbers that we sent out for the overnight stay ones. So that would suggest that locally, although you can never be sure that every single place has done it rigorously, on average, locally, they've come in with numbers that are higher growth numbers than the planning guidance we gave them.
Okay. Ian, Simon? Oh, sorry, Richard first, and then...
Quick part on the two key tests, I guess, for me, looking at this, out of the plans are realistic and aligned, which I think are the two words that you used, Paul. This feels a lot more aligned than it was this time last year. So you reduce some of the risk by better alignment. I guess the thing to sort of really push back on as we go back to organisations is the individual realism as well. So, yeah, alignment, fantastic, reduces risk, but we've really got to keep pressing back on how realistic are the assumptions are, so we don't end up getting any surprises later on in the year. So that's the only part I'd say. That's the bit to keep pursuing in all of this.
So that's the next stage of the assurance process that we're following for providers, and in particular for the acute providers. We will be writing out to chairs to confirm our sense check of the plans and to make sure that the assumptions that we are making before we accept the plans, we understand, and we understand the wider ramifications of those. And I think that's really important that we do that stage in the process that we haven't done previously.
Agreed. Ian, Simon, would you like to close out?
I've got a few words, and Simon may have something.
No, that's fine.
Okay, I mean, I think I'd just pick up on the latter point. I mean, the purpose of planning is not to produce a plan that has the right number, whatever it is, at the right-hand side. The purpose of plans is to tell us what we're going to be able to do this year for our patients. And I think, we are hopefully going to benefit. We will benefit from doing this jointly and seeing this as an NHS planning exercise rather than the disjointed and disconnected commissioner and provider, sometimes in direct conflict planning processes that we've had in the past. But I think it's important we do recognise we're on a journey here. So, thinking about it from a provider perspective, it's true that the the plans in place for 17-18 did see a significant increase in electives planned for Q4, yet at the same time, rightly, emergency patients had to be put first, and those elective plans were therefore not fulfilled. So we're on a journey towards realistic, honest planning, and my sense is that we're moving in the right direction. We're doing that jointly. We can only do this jointly. But I think, frankly, we've still got some more work to do, even at this late stage in the year. And I think I would just echo Richard's point. I mean, my strong belief is at the end of the day we have to have realistic plans that are about realistic patient numbers that match capacity, staffing with the money that trusts have, and that is an interesting conversation that we then have about what we can do for our patients. And I think we're getting there, but we're not quite there yet, and I think that needs to continue even though we're in May. I think we need to get it right.
Yeah. And we need to face into the honest and difficult conversations that those realistic plans present.
I think it's absolutely given. We either have the difficult conversations at the beginning of the year or we have them later in the year when plans that previously have been set haven't come to pass. So that isn't universally the case, but where that is needing difficult, we have to have it now.
But we have one conversation.
Yes. And I must say it is hugely encouraging to hear those that have many more years of planning experience in the NHS than I do, saying how much more joined up this is, that we are ahead. We need to maintain that momentum. So with that, maintaining momentum, I think we should get to the third item on the agenda, which in many ways sums up why we are all sitting here together. A belief that it is in integrated care systems in local health economies that the best possible outcomes for patients and citizens in the country resides. So Ben and Matthew, are you going to introduce the paper briefly?
Yes.
Emphasis on briefly?
Yes, yeah. So as the paper says, it's about a year now since both organisations, again very much a joint endeavour between our two organisations, began work with 10 systems that essentially said we want to come together across general practice, hospital, community, mental health services, across health and social care, across physical and mental health. We want to come together and take a really quite fundamentally different approach to how we manage our collective resources, our people, our estates, our community assets, how we better use those collective resources to improve quality of care for local communities, to improve health outcomes and to reduce inequalities. This has very much been a journey for them, but during that time they've started to do some very exciting things, and this paper can't possibly start to do justice to the range of those things. They've started to do really exciting things to think about how you redesign care and support around the needs of individual patients, typically at although these are generally quite big integrated care systems, all the exciting work tends to happen at populations of a few 100,000, or in a few cases primary care networks covering 30, 40, 50,000, and their main focus has been on how they use their resources better to provide better care and support for frail older people with multiple long-term health conditions, how you provide better holistic care and support for people with mental health problems, how you make sense of what's traditionally been rather a higgledy-piggledy urgent care system, and even looking broader than that and thinking very much about partnerships with local government and beyond, how you support local people into employment. So there's a lot going on. I think two particular reasons why it's important we brought this paper today. The first is that I think there's a lot that these local integrated care systems can teach us about our joint working. I think they will keep us honest in the sense that they're the ones who have said to us throughout this journey, this is how we would like the national leadership of the NHS to act differently, not just in what we do and what we choose to prioritise, but as was discussed earlier, in terms of the style of how we do it. So I think we can use them as a sort of constant sort of weather vane for whether our joint working is having the impact and the value that we wanted to have for local health systems, but also because they've gone through a similar journey to the one we're embarking on, having to think very much about their cultures, their values and their mindsets, how they come together to create common purpose and then execute common system-wide plans. The second reason, this is the final thing I'll say, the second reason why we've brought this to the two boards today is to announce the good news that there'll be a further 4 local health systems joining our integrated care programme. In one case, it's worth just saying that the population is very small. This is West, North and East Cumbria, but West, North and East Cumbria are very much committed over the next year, working with neighbouring sustainability and transformation partnerships to scale up so that by the following year, 2019-20, the idea would be to have an integrated care system covering the whole of Cumbria and the North East. The population size for Gloucestershire is also slightly below the level we'd normally expect, but again, there's a commitment there to work with neighbours to understand how they can collaborate better where it is necessary to do so. We'll also be welcoming West Yorkshire and Harrogate and Suffolk and North East Essex to the programme, and we're very much looking forward to working with them to carry on the journey that other integrated care systems have been on over the last year.
Matthew?
I would just momentarily emphasise the point that Ben touched on about the extent to which this is a bottom-up rather than a top-down set of changes. I mean, this began to an extent with the Vanguard programme and creating networks of GPs and focusing on 30 to 50,000 populations and very close. And what we learnt out of that is that the more you saw vertical integration, the more you saw horizontal integration, the more you saw a population health approach to it, the more successful the Vanguards were. And those have grown into sustainability and transformation programmes across the country, and the best of those are now becoming integrated care systems. We're hoping that they will all make it to that. But as the NHS has worked closer and closer together and been putting traditional barriers to one side to fix stuff, they've been looking to us to do the same thing. And so there is a read-through, I think, directly from the work that started with networked GPs and how do you focus on the needs of a population, right through to the conversation we're having today about why we've brought two boards together. And I think if we remember that this is actually about the delivery of services locally and not about organisational structures at each of the levels, and we will make more right to decisions than we make wrong.
Yes, well said. Open it up. Anyone would like to add to that? Simon, is there anything you'd like to?
By going ahead with these four, that's 12 million people, slightly more than 12 million people across England now who will be beginning to benefit from the joined-up services that Matthew's just described. So we're going to be publishing next month the results of the final data from the Vanguards. We talked about this a bit this morning, and I think what that will show decisively is that not only does it improve patient experience and the quality of care, but it does help relieve avoidable pressure on hospitals through emergency admissions, and the data are now quite compelling on that point, and we'll be publishing those, which I think will put further fuel in the tank of the journey that we're on.
Steve?
Yeah, so I'm going to repeat the comments I made yesterday in our private session, that I think what it's imperative that we do nationally, regionally, with our nascent integrated care systems and with our patients and the public is really double down on describing the narrative as to what difference this will make if you're a patient, if you're a member of a local community, if you're a population, so we can set the expectations for integrated care systems so it's clear what we want them to achieve, and actually probably more importantly, we set with our patients and public an expectations as to what they want to achieve and what they can expect out of these changes.
And you made the point very powerfully yesterday, Steve. I think that there's a real sort of learning for us in all of our joint working that it's important to describe what you mean. The danger is often we use the same words and walk away thinking completely different things. And the more we can describe in the terms that our mums and dads and grannies will understand, because we're speaking simple, comprehensible, ordinary English and describing the change we want to see through the eyes of patients and citizens in everything, whether it's our joint venture or integrated care systems, I think the better we will do. It's a very powerful point for all of us. Any other final comments? Otherwise, I think that's rather a good place to end the meeting as a whole. I don't know, Malcolm, if there's anything that you'd like to add at the end?
No, I don't yet. I think this is immensely encouraging, and there's huge wisdom around the table. And a commitment to doing these things much better than we've done in the past. But it's not about these organisations. It is about facilitating the growth of integrated care systems across the country, which come from those who will lead them, will run them. So the future operations for us and for those who work for us is how we facilitate that. and how we refocus our efforts on trying to bring that about and make it easier for people who want to bring about beneficial change locally to actually do so. So thank you very much, everybody, for helping us to get in that direction.
So with that, I think we should bring to a close our first joint NHS England and NHS Improvement board meeting. I look forward to the second joint meeting in September, but I have no illusions. There's a lot of joint work for us to do, both executives and non-executives, between now and then, and we will make sure that there are the right gatherings and groupings to keep the momentum and, if anything, accelerate. So thank you all very much.
Thank you.